Region of the heart will be cardiac comeback. What's cardiac comeback?
Protrusion of the heart region.
Protrusion of the
Heart region extension.
Protrusion of the protrusion of the bones.
Okay.
Protrusion of the bones. So first you look at cardiac comeback. So in inspection, no touching. Okay. Patient is here. You are in front of the patient. Just look. Cardiac comeback. So in this case, there's no cardiac comeback. So absence of cardiac comeback. Okay. Next, we go to point of maximal impulse. Okay. Point of maximal impulse. What's that?
Apex.
Apex speed, of course. Apex speed. Where are you supposed to stand for? To look point of maximal impulse. In front of the patient or where? Behind? Laterally. So you go laterally or you go that side or this side. Anywhere. Okay, you stand laterally and you look. Point of maximum impulse. Normally, where is the apex speed?
Fifth intercostal space.
So you look at your fifth intercostal space from here. Can you see pulsation? Okay, can you see any pulsation? No. So absence of pulsation of apex beat. Okay. When can you see pulsation of apex beat? In which type of patient?
Enlargement of right ventricle.
No.
In which type of
asthenic
patients? Yes.
Okay.
Asthenic patients, pulsation of apex beat is visible. Okay. So in this case, it's not visible. So you just see apex beat is not visible. Okay. Then you come back in front. Next would be cardiac beat. Cardiac beat. In which part of the body you look for cardiac beat?
For the intercostal space.
Are you sure? For the cardiac beat. Cardiac beat mana?
Just in your
In which part would you look for cardiac beat?
Yes, I recall it.
Cardiac beat in the
It's left parasternal. No.
Oh, you mean that space?
usually we look here, like, in the epigastric area here. In this area, we look for cardiac beat. Okay. When can you see cardiac beat? Okay. In a normal person, is cardiac beat visible? No.
Don't think so.
No. Okay. In normal cardiac beat is not visible. So when can you see cardiac beat actually? When there is a
Hypertrophy.
tumor. When there is a mediastinal tumor, cardiac beat is visible. Cardiac beat is visible. When there is a mediastinal tumor, because the tumor would be inside, it would push the what? Push what? Push the vessel. The vessel. Vessels are here. It will push the vessel outward, so the vessel would be, it would be near your bone. Then you can see the pulsation of the vessel. Okay. Sure. Next, abnormal pulsations. Aorta pulsation. Which side do you look for aorta pulsation?
Right side.
Right.
Second
ICS. So you look at second ICS. Absence of aortic pulsation. Next, pulmonary trunk pulsation. Which side of the chest? Left side. Pulmonary left side. Left side. Which space? Second ICS also. So absence of pulmonary. What is a pulmonary trunk pulsation? Next, ventricular aneurysm. Where do we look for ventricular aneurysm? Fourth or fifth. Fourth or fifth ICS. Where? Left or right?
Left.
Left. Which part of left? Is it mid-axillary or mid-clavicular? Where?
Mid-clavicular. Mid-clavicular. No.
Yeah. Mid-clavicular sini. Parasternal.
Oh,
Fourth, fifth, left parasternal. That is where you look for ventricular aneurysm. So, in this case, absence of left ventricular aneurysm. Okay, so we have finished with the region of the heart. So it's up to you. You can see first everything, then you can explain one by one, or you can say first cardiac comeback, absence of cardiac comeback, then you just move on to the next, or you look everything and then you give your general conclusion. Absence of cardiac humpback, absence of cardiac beat. No? It's up to you, which you feel comfortable. But all this you can hafal. You must hafal all this. In the exam you can't be holding the paper. Okay, nothing in your hands. Okay, next, region of the neck. So here also, no touching the patient. Okay, first, aortic arch pulsation. Where do we look for this aortic arch pulsation? Yes, into jugular fossa. So in this case, absence of aortic arch pulsation. Next, carotid arteries pulsation. Where do you look for carotid arteries pulsation? On this side and this side. So you look.
What is that side called?
Which one?
What is that side called?
What muscle is this?
I mean, what is that? If she asks this,
carotid arteries pulsation.
Do we have to ask patient to understand?
No, usually you don't need, because it is very visible. Because your carotid artery is here, so you can feel the pulsation. So you don't need the patient to turn. You can just look at both sides. Absence of carotid arteries pulsation. But when you can see carotid arteries pulsation?
When?
And in which cases you can see? Aortic arch pulsation. When can you see?
Hypertrophy of the heart. Maybe.
Yeah, hypertrophy, yes, but what's the main cause? Aortic arch. So something to do with the aorta, right? So aortic insufficiency. Okay, you can see aortic arch pulsation. Okay, that if it's something to do with aorta. Something out of aorta, extra aortic pathology. In where? Which are the cases? Thyrotoxicosis. Okay, in thyrotoxicosis, visible aortic arch pulsation. Okay, but you must also remember, in asthenic patients, when they are very, very thin, it's visible. Okay, but usually it's not visible. Okay. Next, engorgement of jugular veins. Which vein? Engorgement of jugular vein. Which vein? Which vein? Okay. So, engorgement. So the same thing. You look here. Look for the engorgement of the jugular vein. So usually it's not visible. So you just say engorgement of jugular vein is absent. But when can you see engorgement of jugular vein? Why I'm asking you all this is because in practicals they would ask. It's not only practicals, because if the teacher is Dronova, right? She won't be asking you anything. She will be just standing there. Scarface would be there. Julia would be there. What's the other name? Yelena is Scarface, right? Scarface,
Irina.
Julia, or the one in Irina and the one more.
Dimitri.
Not Dimitri, the lady in Sayusnaya. What's her name?
The model.
Anna.
Yes, Anna Tibazova. They would be there asking you questions. So they would ask, why? Why not this, why not that? So you must know. Okay. So when can you see engorgement of jugular veins? Jugular vein? Where's jugular vein? But think. Where's the vein? In which pathology you can see?
Anything that causes the CVP to increase.
Yes, CVP. So that's what. Increase in what volume? Jugular vein. Systemic volume. Increase in systemic volume would cause engorgement of jugular vein. Another pathology? What other pathologies? Very frequent. Everyone, most of us. I mean, not us. Most of the people would have this. Systemic hypertension. Okay. In systemic hypertension also, engorgement of jugular vein is visible. And another one would be where? In tricuspid regurgitation. In tricuspid regurgitation, engorgement of jugular vein is also visible. Okay. Next, we are finished with this. Next, regular venous pulse. Okay, regular venous pulse. When you are going to inspect about regular venous pulse, what is the position of the patient? Regular venous pulse. Position of the patient is Regular venous pulse. How do you measure?
Lying down.
How do you see? Patient supposed to stand or sit?
Lie down. About
Lying
45
down.
degrees.
Lying down. Patient has to lie. Okay? Patient has to lie. And then regular venous pulse, there's what is negative or positive. So for normal, it's negative or positive? Negative. Why negative? Why it's negative? How do you know it's negative? How are you going to check? How are you going to verify that it's negative? What are you supposed to compare with? When you say this venous pulse is negative, with what do you compare usually?
The height. The height of the pulse. No.
Yes, of course you look for the height of the pulse, but with what do you compare? How do you know it's negative? Because we say negative is normal. With what do you compare? With your apex speed. You compare it with your apex speed. So, what's with the apex speed and this venous pulse? It must be asynchronous. Okay, your jugular venous pulse and your apex speed must be asynchronous. Okay, so the pulse is asynchronous with the apex speed. If it's positive, it is synchronous. Okay, so in normal, jugular venous pulse is negative. Why negative? It is asynchronous with the apex speed. Okay.
What does asynchronous mean?
Asynchronous means not symmetrical. Asynchronous. Synchronous means they are
Same.
the same time. Pulses. Asynchronous, that means first here, then here. First, second, first, second. It's like your normal heartbeat. S1, S2, S1, S2, S1, S2. Okay? It's asynchronous. And when do you get positive venous pulse? In which disease? Which disease? Tricuspid regurgitation and right-sided heart failure. Okay? Right-side heart failure or tricuspid regurgitation, you can see positive venous pulse. Okay. Next, we just move on to trachea. Trachea, first thing, look. Okay, you inspect first trachea, then you are allowed to palpate. You are allowed, but look first. Okay, look in the region of trachea, then palpate. Palpation of trachea. How many methods do you all know? What are the methods? 3 fingers, 2 fingers, and 1 finger. So if I'm going to use 3 fingers, so this would be in the middle. Okay, and here I fix it, then I come down. Okay, next I'm using 2 finger method. Will be here. Okay, then comes down like this. Alright, if you want, you can even go up to you. Okay, next 1 finger method. Just use the finger and do. So now his position of the trachea is midline. Midline position of trachea. Okay, we'll just say that. Next, tracheal tuck. What's tracheal tuck? What's tracheal tuck?
The movement. I think the movement of the trachea inside when you inspire. During inspiration, is it? No.
During
inspiration.
Systole.
Systole. Oh.
During systole, tracheal tuck happens. So, how do you actually check for tracheal tuck? How do you check for tracheal tuck? Simple.
The same method.
That's it. Just hold the trachea, but patient incline backwards. Okay. Hold the trachea, then just try to push the trachea up. Okay. Just hold it up. If there's pathology, you can feel the trachea moving down. But in this case, you move it up. No, nothing. So tracheal tuck is absence of tracheal tuck. Okay. But all this you better reconfirm with her, because this Dronova, she changes her methods time to time. So just reconfirm back with all this stuff, because it's very important. Okay, next we go to peripheral arteries pulsation. First one, capillary pulse, Quincus pulse. How do you check for Quincus pulse? Quincus pulse. Nail, tongue, white tongue.
No, that one is the same, but then you need a slide. So in the slide, you just press the finger.
So you take the patient's position from your finger. Then what do is here, okay? Just press on the nail, okay? And you see if there's a pathology, right? Okay. Can you see the white area here? Okay. In the white area, you can see pulsation. That's Quincus pulse. Okay, but now once you click on, there's no pulsation, so normal. Quincus pulse is negative. No Quincus pulse.
Once you check both hands,
One hand. Okay, so just take the patient's hand, just press on the nail and look. If there is the pulse, you can see. You can see the pulsation actually. Okay, you can see the nail bed there, it will be pulsating. Okay, that's Quincus pulse. Next, vigalness of arteries, worm sign. Where do you look for the worm sign? Yes, correct. On your here, usually on the hands. So just look at patient's hand, worm sign. So in this case, absence of worm sign, of course. Okay, but when do you get this worm sign? In which disease?
Atherosclerosis.
Atherosclerosis, yes. In atherosclerosis, it's very, very prominent. Okay, you can see worm sign. How does the worm sign look like? Right, when you look at patient's hand, the arteries will be all like a worm, like it's all wiggled. Right? Wiggling of the arteries. So you can see that. Okay. Next would be epigastric pulsation. Okay. How many types of epigastric pulsation do you all know? How many types of epigastric pulsation do you all know? How many? Or is there only one type of epigastric pulsation?
One type.
Only one. There are 3 types of epigastric pulsation. Okay. See, epigastric pulsation is where? In this area. Right? Okay. So, what can cause this pulsation? So, think now. What's in this region? What's in this region?
Cardiac.
No, correct. It's somewhere above here. But what's in this region? What can you see? In what organs? What's that?
Stomach.
Stomach, sini.
The
Heart. Which part of the heart? Right ventricle. Yes. So right ventricle is here. Okay. So right ventricle can cause pulsation of epigastric pulsation if the right ventricle is enlarged. Enlargement of right ventricle or right ventricular hypertrophy can cause epigastric pulsation. Okay, that's the first one. Second, liver. Which part of the liver? Which lobe?
left lobe.
Left lobe, of course, left lobe. Yeah, left lobe of the liver. So your liver is here, kan? It goes like this, it comes here. Betul? Okay. So left lobe of the liver, if it's enlarged, it enlarges towards this side. Okay, left lobe enlarges towards this side. So that enlargement also can cause epigastric pulsation. Okay, that can be one of the cause. So this is the second one. What's the last cause of epigastric pulsation? What's running here? Abdominal aorta. So abdominal aorta, if any pathology in abdominal aorta, it would enlarge and cause pulsation of abdominal aorta. So that pulsation can be seen as epigastric pulsation. Okay, so there are altogether 3. Okay, right ventricular hypertrophy, enlargement of left lobe of the liver, and abdominal aorta. All these 3 can cause epigastric pulsation. So in this inspection, what you need to do is this. You look and you look. No pulsation, absence of pulsation. Okay? But if there's actually a pulsation, how do you differentiate with hepatic pulsation and right ventricular pulsation? How? Okay, let's say it's pulsating. Okay, you can feel it. You put your hand here and you can feel the pulsation. How do you differentiate if it's hepatic or right ventricular? How? Not flash sign. Flash sign is different. If it's right ventricular enlargement, your pulsation is only from one direction. The pulsation will be coming from here. Okay. Because here's your heart, kan? So when you put your hand, you only can feel the pulsation in one direction. Okay. But if it's because of hepatic pulsation, okay, hepatic pulsation, the pulse would be expansible pulse. That means it's like not coming from one, but it's like the whole thing. You can it's like, it will be like radiating, expansible. No? It expanses. So once you put your hand here, you can feel like your whole hand is being pushed. So that's because of hepatic pulsation. But once you put your hand and you feel the pulse coming from one direction, then that's because of right ventricle. Okay.
This is not in inspection, but
no, this is not inspection.
But you can.
No, you don't touch. You don't touch it.
Like say when we inspect, we see there's pulsation. Then how do we?
Oh, you mean how you know if it's? No, this I'm telling you if you want to know.
I see.
I mean for exam, this is under inspection. But for your future, in your future practice, of course you need to put, right? Without putting, you wouldn't answer. But if she asks in exam, tell me how do you, so then of course you need to tell. So in this case, I have to palpate the patient. No, you have to inform them. No? If they ask you, how do you know? So in this case, I have to palpate at the epigastric region, and then you tell. You tell the characters of this pulsation. Okay. Next, flash sign. How do you do flash sign?